one very important clinical question is, how do you guide your resuscitation? What should be the endpoint of resuscitation? So several endpoints are being used at present in clinical practice. And the studies have shown to utilize multiple parameters as the endpoint of resuscitation. For example, we have the famous EGDT trial by Emmanuel Rivers and colleagues, where SCVO2, central venous oxygen saturation normalization of more than 70% was used as the endpoint of resuscitation in the intervention arm. Whereas the study by Jensen and colleagues, lactate normalization was used as the endpoint of resuscitation for resuscitation of septic shock patients. At present, the Surviving Sepsis Campaign guideline is suggested resuscitation guided by lactate as the endpoint of resuscitation. Shall we use lactate or SCVO2 or clinical endpoints, or shall we use some measurement like capillary refill time? So I suggest that we should not be using endpoint of resuscitation based on only single parameters like SCVO2 or lactate, but we should be based our resuscitation target on multiple parameters. But out of these parameters, probably the most useful parameter is capillary refill time, because it is universally available. It can be applicable to almost all our patients, except probably patients with severe peripheral vascular disease, or patients with Raynaud's phenomenon, or patients having too much dark skin, or maybe patients who are hypothermic. So basically, it can be utilized for majority of our critically ill patients. Secondly, now we know that we have a reproducible way of measuring the capillary refill time, and which has been shown in the Andromeda shock trial, where the tip of the index finger can be compressed with a glass slide for 10 seconds till it is blanched. After 10 seconds, remove the glass slide, let the skin get back to its normal color, and the time taken to get back to the normal color from the blanching is the capillary refill time. If the capillary refill time is more than 3 seconds, it is prolonged. If it is less than 3 seconds, it is normal. So this can be used for almost all critically ill patients. Furthermore, capillary refill time kinetics has been shown to be faster compared to lactate, or compared to SCVO2, or compared to other parameters. So the normalization of the capillary refill time is faster compared to normalization of the lactate. Lactate takes a lot of time. In fact, lactate has got two different kinetics models. Initially, lactate becomes normal faster, but in the later on, it takes a second peak. Then beyond a certain point, in many patients, lactate normalization is slower. We know that CRT measurement doesn't involve any additional cost. So this is also another advantage of CRT over other parameters. Finally, there are some two clinically important parameters why we should use CRT compared to lactate kinetics. First of all, Andromeda shock trial has shown us that cumulative fluid volume at the end of 8 hours of resuscitation is lower in CRT guided group compared to lactate guided group. Similarly, organ dysfunction score was significantly better in CRT guided group compared to lactate guided group. Further analysis of the Andromeda shock trial data has also shown that patients who are resuscitated with CRT guidance compared to lactate guidance shown to have lower mortality. So based on so many evidence, possibly one single parameters we should be utilized for guiding our resuscitation, that should be capillary refill time. But again, just to re-emphasize, it should not be considered alone. It should be considered along with other clinical parameters, including lactate, if it is available.